All right, so acute principles, blood, IV fluids, and shock. We start to incorporate IV fluids towards the end because they're priority to shock and revascularization of a patient that has an acute principle, especially with trauma. All right, so sepsis shock. Okay, so generally, we're going to start with the person, right? So I mean that's priority because the patient is septic, right? So, an aseptic patient is an acute patient, so we know they're going to be acute, and they're going to have problems with fluid and fluid volume. So they're going to be from a normal volemic state, and then they're going to go to a hypovolemic state. So they're going to become vasodilated, all in the peripherals out here. So all their alpha is going to be vasodilated. And that's a big deal because that's what this is all about. And this is where the rule comes in. You fill the pump before you squeeze. And we said that acute alpha squeezed upside down is vasoconstriction. And so you fill the pump, then you squeeze. And this is all about vasoconstriction because in septic patients, they can't squeeze. And that's why it's such a big problem. So blood pressure is huge. So you're going to be monitoring this patient's blood pressure. And actually, you might even have an A-line in, and you'll be monitoring that dichrotic notch. And that dichrotic notch is going to give you your systolic and diastolic. And we'll be monitoring this for dampening. And if it's dampening, we're going to be putting that patient on the semifollowers. So we're going to be looking at the phlebistaxis line. And we're going to be looking at that to make sure, because we really want to know what the blood pressure is. Because their blood pressures might be 80s on 40s, right, with low mean arterial pressures. Mean arterial pressures, they're going to be an acute renal failure. And what kind? Most likely it's going to be pre-renal. So we're going to be very concerned about that. So we're going to put a Foley in this patient, and we will monitor their urine output. And we're going to be monitoring that urine output for 30 cc's an hour for 424 hours, because our biggest concern is going to be this pre-renal failure that the patient is in. So that's why we'll put an A-line on, and that will be up in a pressure bag. And that pressure bag is going to be acute because we need to continually monitor this dichrotic notch and make sure that we have a solid blood pressure running, because that perfusion is everything, that this urine is coming out. Now, another thing too is, so we'll also be doing a manual blood pressure. We're going to put a line in them. We'll have a Foley in them. What else are we going to do? The patient is probably going to be vented at this point. And this ventilation is going to have an ET cuff, and we're going to check that cuff pressure, right? And that cuff pressure should be puff cuff 420, right? So 20 to 25. And we're going to use a sphigometer for that to monitor this cuff pressure to make sure that it's patent and that those lungs are being perfused. And now that's easy because that ET tube, there might be a 75 at 23 cms at the lip, right? And we're going to have some vent settings for this patient. We'll probably be in assist control mode, and that rate might be around 14 or something like that, 12, 14, 16, which is a normal respiratory rate, because the principle is that this patient is hemodynamically unstable, but we're going to handle their ventilations at this point. We're just going to ventilate them and keep them going. So we're going to make sure that they have a tidal volume, whatever their range is, 750, and then FiO2. So we'll put them at 60%, and we'll put our PEEP on there. So we'll do a PEEP of 5 for this patient. So they'll be hooked up to this ventilator, and so we'll put this ventilator over here, and we'll be monitoring that ventilator. And we'll be monitoring that tubing, which we talked about for pressures, right? So high pressures is kinks in tubings or disconnection, right? So this ET tube would be connected to that. And that VAT tube would be over to suctioning as well. And that's going to prevent this patient that's now on a ventilator for sepsis from becoming aspiration pneumonia on top of it. So we'll put a VAP tube in there. We're going to put an ET tube in there. And then we're going to put an OG tube down there because the body's going to be shunted. So we're going to put them on life-saving protonics. So we'll definitely have an IV over here. But this patient is going to need to be fed because all these cells are now starved, right? And they start to break down and they start to have this mass inflammation. That mass inflammation causes extreme vasodilation. So what we're going to do is we're going to put them up in TPN, right? So we'll probably put a triple lumen in. So let's throw that in here somewhere. So put a triple lumen in, and in that triple lumen, you're going to have 3 ports to that, right? So on that port we just talked about, we're going to put TPN in that, usually TPN proximal, right? So TPN, and TPN will be up. And we'll need some sedation because they're going to be vented. So we're going to put some sedation up. We're going to put some propofol or something like that. Because they're on propofol, we don't need to give lipids for this patient because propofol is lipids, right? So therefore, we're going to monitor this patient's lipid profile. Because the big risk is that triglycerides and their LDLs are going to become acute. So we'll monitor their cardiac enzymes as well because the risk is that they have an MI, and we don't want that. So therefore, we're probably going to put them on definitely going to have them on a monitor. And we're going to monitor that patient, and what we'll do is that we're going to be looking for ST depressions or even ST elevations. Now think about this. If this patient is on this monitor, and we're monitoring this patient and we can't see them saying, hey, I have chest pain right now, anything like that. So we're going to be monitoring these enzymes over here because the risk is that this patient has a myocardial infarction while on it because they're on propofol, right? So, I mean, that's something that we don't want. And also, remember we said we're going to fill the pump before we squeeze. So it's going to be pump, 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 pump. So it's going to cause a lot of stress onto that heart. It's going to cause a lot of problems with that. So we need to monitor that. So how do we monitor? We monitor the enzymes over here, but we're probably going to put a swan in them as well because the problem is like, how do we monitor the hemodynamics? So we'll put a swan in there, which we're going to put down here, and then we're going to monitor their CVP readings, right? So we get their CVP, which is the CVP, which is the peripheral, right? So we're going to fill the pump before we squeeze. So they might be less than 4. And so we're going to increase the fluids because we want their range to be higher, right? We're also going to be, which we're going to monitor the cardiac output, and we want that cardiac output to be 4 to 8. We're going to float a swan into the pulmonary artery, which is going to give us our pulmonary artery wedge pressure. And that pulmonary artery wedge pressure should be 8 to 12. So we said that the patient's going to be really dry, so it'll be less than 8. So we're going to try to keep them in that sweet spot of 8 to 12 because we're not really sure where they're going to be. Let's get another line over here if we can fit it in, maybe a 22 because it's near the wrist. We're monitoring the vent for peak pressures. We are monitoring their A line over here, and we got their BP cuff still running every 15 minutes because so we're going to generally hold heparin. We're going to be concerned about that because the risk of bleeding is priority. So because of that, we're going to put some SCDs on them. If we question that the patient is throwing a clot, of course we're going to check their BMP. That makes sense, right? Because the fluids are going to be all over the place. I'll be up and down. Potassium, because we're probably going to put this person on a Lasix drip if this person's pre-renal isn't in renal failure yet. So we might even actually put them on a Lasix strip or a Bumex strip just to keep them going. Where would we put that? I don't know if it's compatible over here, so I might put another line in over there. So I'll monitor the chloride and CO2. That's going to be all over the place. The BUN I'm always monitoring because that's going to be high. Hopefully they're not in renal failure yet because I'm going to be looking at their GFR down here. And that GFR, if it drops less than 60, that's going to be acute. Glucose is going to be all over the place. This patient's going to be on mass steroids because of inflammation. CBC, of course, the white count's going to be elevated, so I'm going to look down to the differential because that differential is going to tell me how well is this patient monitoring. And so that's going to be elevated 18, whatever it was before, 28,000. H&H, well, as the patient has this bleeding that's going on, remember the vessels, all those vessels are all irritated. And because they're all irritated, they take a lot of clotting factors. And that goes back to this over here. And this clotting factors all start to eat up is that this patient's platelets start to go down. And so this patient will start to bleed and go into its DIC. So we'll monitor that H&H because of that problem. We're also going to be monitoring their calcium and mag because the patient is going to be on these diuresing, and they're going to be diuresing, and they're going to be getting lipids, and we're going to monitor their phosphorus as well, because as they go into acute renal failure, where they're at risk for hypophosphatemia, which means that the patient will start to go down. In addition, we're going to monitor their liver enzymes, and the reason we'll monitor their liver enzymes is their AST and then their ALT. And the reason we're going to monitor that is because of when we talked about these lipids over here from the propofol, and also the problems with mean arterial pressure. Because as a person starts to hypoperfuse, they start to have more problems, and you start to see organ failure. So we're always trying to prevent multi-organ failure from happening. And so while we're at it, because they're going to be on this, we're going to make sure that we're going to do an ABG. So that ABG will be monitored, and we'll be monitoring that pH. And that pH will be low because of acidosis, because it is so acidotic, because of all this problems over here. And so we'll be continually monitoring that every single day. Luckily, we have an A line to do that from, because otherwise we'd be keep on having to pop them here, pop them here, pop them here. And so we couldn't do that. All right, so what else are we missing? Antibiotics, right? That makes sense, right? Because they're in sepsis, so we would need to have some sort of antibiotics. Well, where would I put them? I don't know. You know, I would have to check compatibility. So maybe I put them on some heavy-duty Vanco, right? So, well, that's a level medication, so I need to make sure I know the levels there. So we know it's 10 to 20, and I'll assess that level, and I'll have to check those liver enzymes again, right? But that's probably not going to help, because I need to do broad spectrum, so they'll probably be on farting flagyl on top of it, because of I'm going to wipe them out on their whole GI flora. So I got to throw up flagyl. Flagyl doesn't like anything, so maybe I have an open line at certain times, and I'll give flagyl here, and then I'll throw that up, and so I put the flagyl up there. But how's the patient doing? That's the biggest concern. That's what I'm trying to figure out, right? So do I even know where they're at, right? Well, let me put a BIS on them. You know, I could do that. You know, I could check their brain. So I'll put a BIS on them, and that's how I can monitor them. And we talked about that before. So now they're going to start to really blow up, because I give them so much fluids and everything like that. So hopefully their renal. So they're going to need some vasopressors. I forgot the vasopressors. So I'm going to put those up. And so those vasopressors, so I'm going to put level fed, leave them dead, right? That's acute. And definitely some neo, maybe hopefully that's compatible. I put that aside over here in between the flagyl. So I'll put that neo up, and I'll be monitoring that. And then I can kind of go from there. Well, they're going to be really clamped down, so pulses are going to be a big issue, because that fluid are going to fill up and everything like that. So I'm going to mark their feet. So I'll be checking their pulses with Dopplers every once in a while. They'll probably be definitely, you know, so I get the vasopressors up. Well, maybe their cardiac output's really starting to drop, right? So I need something that's going to pump that, like dobutamine. So I'll hook that up here. That has to go from a central line as well. So I'll put that dobutamine up there, and then I'll have to monitor that. Yeah, that's about it. All right, so that's a septic patient. All right, so let's start with the cascade. So that's the first step. So when we're talking about the cascade, you know, this is what this is all about. All right, so let's talk about sepsis. And today we're going to talk about sepsis in the sense that what's happening. All right, so when you have a person who is septic, right, so think about sitting on a tack, right? So there's a portal of entry, okay? And that portal of entry is like this, okay? So there's an entry here. And what you have here is you have cells here. And the basic of who we are is we are aerobic, right? So we're aerobic means, you know, we take in oxygen, and oxygen goes to the cells, and that's kind of what happens with our metabolism. That's how we start to understanding that concept makes us aerobic. All right, so the byproduct of aerobic is normal metabolism. Normally what happens? So normal pH, normal everything, normal hemodynamics. Okay, well, in sepsis, that's not happening. So in sepsis, you have some sort of portal of entry. You have infection. And when you have infection, you have an elevated white count. right? And that's why we always ask, what's the differential? And what was it before? And the reason that's important is, where were they before? All right? And that's why febrile, bacterial, could become sepsis. That's why it's acute. So you do blood cultures. So we do 2 sets of blood cultures, right? And the reason we do 2 sets, because poor nursing, all right? Because of error. Right? So you might contaminate 1, but likelihood of you contaminating 2 is not as likely. So that's the difference, all right? So you do 2 sets, 2 separate sides. And that's why we do it. So we see an elevated white count. What was it before? What's the differential? And where's the source of infection? Okay. The patient can become uroseptic. The patient can have an injury. Okay. They could perf. They gut perfs. And we talked about that with, that's why that person has that NG tube or that OG tube. And we talked about how, you know, the person, why they need a Miller Abbott or a Salem Sump, right? That's an ET tube, sorry. Because they suck off the mucosal layer. If you suck off that mucosal layer, the gut is dirty, has a lot of bugs in there. They go out that and they go into what's enterohepatic. So the bugs live in this little section, and what happens is that they multiply. So then the patient starts to cook, and then they become septic. So that's why we put them on protonics, because we know this problem is going to happen. They're going to be shunted. So we prevent a person who's on a ventilator from becoming septic by protonics, and they become life-saving because we're preventing bug migration and stress ulcers in the body. So when a patient is septic, we also don't want them to have a live-in tube or something like that, because we don't want that mucosal layer to become ischemic. If it becomes ischemic, it becomes broken, starts to bleed, and then you start to have bugs migrating out, causing further sepsis. Right? And I think we had a question about that, right? Perf ulcer. Perf ulcer is acute because of migration of bugs. All right, so with this issue, the person has an injury, okay? And normally, they're all breathing fine, taking oxygen, hemoglobin, right? So hemoglobin, right, erythropoietin from the adrenal glands, goes to the liver, then it goes down to the bone marrow. And then we have red blood cells. Well, prior to leaving, they get rid of their nucleus. Why? So they can move around and carry more O2. That's the point. So that's why they only live 120 days, because they will die, because they have no nucleus. So, all right, so, but they carry oxygen to these fingers and toes. Okay, so that's all good. Well, that works for a little bit, but they have an inflammation right here. So what happens is inflammation. So these cells start to swell. Okay? And they start to swell, they become interstitial. And once they start to swell, these cells down here don't get oxygen. Okay? So they start to get a little bit pissed. They're not getting oxygen. And so what happens is they're not going to die first. That's the first key. You know, cells never say die, like Goonies, right? So, yeah, to quote a movie from 40 years ago, maybe. Yeah. So the cells are all starved of oxygen. Well, the issue is it comes down to that Krebs cycle and ATP and oxygen, aerobic, right? So now all of a sudden, these cells are living without oxygen. Right? So they're all living without oxygen down here. Well, the byproduct of that is they're a little pissed and they spit out lactic acid. And this lactic acid, think about it, it's acid, right? So this lactic acid comes into the vessels, into these blood vessels, okay? And it's caustic to these vessels, right? And so it irritates these vessels. And then what happens is, in that irritation, they vasodilate, okay? Hence, the person was euvolemic. They had a normal fluid volume before, and now in the presence of lactic acid, they suddenly become hypotensive, okay? So that's a big issue because now they're hypotensive. The reason they're hypotensive is because of this lactic acid. So, increase of lactic acid is positive for sepsis, okay? Yeah. So, all right, so what's going on? All right, normally we're aerobic, but because of this inflammation down here, these cells are not getting oxygen. So what they get is they still do what they're doing, but they're in an anaerobic metabolism. They become catabolic. They start to produce lactic acid, and it goes into the bloodstream, and all of a sudden they're normal volemic, they vasodilate. Blood pressure drops, okay? So stay with me. So the rule is, in septic patients, you fill the pump and you fill it up, right? 4 to 6 liters. And that's what's going on. Is so when we're looking at this patient, they are septic. So when you're looking at this is just one little microscopic area. But when you're looking at a patient in their vasculature, their SVR went from this to this. So they plummet, okay? And that's why they become septic. And that's why it's an emergency. And that's why it's so acute. And this is what we need to deal with when we have a patient who's septic. So what do we do? So how do we manage this patient, right? So, well, the first thing is we fill the pump. We draw lactic acid. We draw blood cultures. And we start antibiotics right away. That's why you see sepsis protocols and different things like that. But what about this cascade? Why do we care about this cascade? Well, the principle is this. Now, this is, I don't test on this clotting cascade, so don't worry about it. It's just sit here and just listen to it. Why is it important? It's going to tell you why they bleed and what's going on. All right, so we just had a person in a clotting cascade. So the person has lactic acid in here. In all their vessels. So just think about this. All raw, inflamed, and all these basically caustic, right? Which causes, if you think about like the normal arteries and all that stuff, you know, they're muscles, right? But now they're all damaged. So they can't quite squeeze. So they're very boggy. So lactic acid is here, but all this injury is here. You have mass injury, okay? And that's why this is important. So let's talk about this. So you have a thing called the clotting cascade. And what we do have is we have circulatory platelets. And these platelets come over and they start to form little clots. So antiplatelets, like aspirin, we talked about with cardiac. Remember we said that cardiac, when you have cardiovascular disease, you have this kind of inflammation going on. Well, or damage, as you know. So the risk is, well, if we know the person has CAD, we tell them take low-dose aspirin because we don't want these little clots forming, okay? And that's kind of why. Well, that's an antiplatelet because platelets are the first aggregators at the site, okay? So septic patients will have their platelets will start to form on these vessels and on these areas of injury all over the place, okay? So platelets start to decrease in septic patients, right? Okay, well, that's the first line, but they have the clotting cascade, okay? So let's talk about the clotting cascade and why is it important? Well, clotting cascade is like this, and I call this 10 over here, 10, which is 12, E, 11, 9, and this is 10, 10A, okay? And then this over here is 7. Okay, lucky 7. All right. So E before I. So extrinsic before intrinsic. So extrinsic versus intrinsic. Okay, so stay with me. Extrinsic, Coumadin. Person goes home on Coumadin because it deals with extrinsic factors. So Coumadin on this side, C before H, heparin. Okay, so Coumadin is an extrinsic factor. Heparin is an intrinsic factor. Right? So a person doesn't go home on heparin. Why? Because it's intrinsic. It works on all these clotting factors. Where this extrinsic factor, okay, so when we talk about that, so let's talk about this. Intrinsic, inside the cell, in the cell wall. Extrinsic, outside. Okay, that's kind of the basic principle. It's more acute inside the cell and what's going on inside. All right. So extrinsic, intrinsic. Okay. So Coumadin also we affect the slabs, right? So we know the PT, right? So you have PT down here and PTT. Okay. So these are all prothrombin times. How long it takes prothrombin to become thrombin. Okay. So, why do we care? All right. We care because remember that? All this stuff? Well, in order to form a clot, you need all these clotting factors. You just can't form a clot. It takes time. It takes clotting factors. So, when a person, so we said 12, 11, 9, 10, 7. So now we have 8, right? So factor 8, and you've probably heard this before, factor 8 deficiencies, right? So factor V, 1, 2, 3, right? W, Willie Brands. Von Willebrands is factor 8 deficiencies. Hemophiliacs, factor 8, right? Liver patients, factor 8. Because everything down here is liver, right? Because liver creates factors. And people who have liver disease have a propensity to bleed. So factor 7, no, factor 7 is up here, sorry. Then goes 6, then 5, and goes on down. All right, so then you have what's called fibrin. We saw that on that slide. Oh, Janus is first to become fibrin. Okay. All right. So, what does this mean? You have an injury, okay? Platelets come around, say, hey, you have an injury, okay? So they aggregate. 7 sees it. They climb on board and say, okay, there's an injury. Boom. This process happens, prothrombin, fibrinogen, okay? These factors, because the injury, so if you think about this, extrinsic, intrinsic, are already in the cells, start to form a matrix. 12, 11, 9. 8, 7, 6. Next thing you know, you have a clot. Okay? All right. That's how a clot gets formed, through this clotting cascade. It's much more complex than this, right? But don't worry about it. It's not, trust me, I don't know it anyways. But the principle is important because you have mass inflammation of injury. So you just keep on using clotting factors. Okay? And so what happens is you only have so much. You only have so much clotting factors. And then what happens is start to go like the DIC and you start to bleed. So in septic patients, when they start to bleed, bad. You're at the last stage. They're not coming back. So we're trying to prevent this person from going down the clotting cascade, which means that they keep on using their clotting factors. They keep on using them. They're using them. They're using them. They're using them. And next thing you know, they start to bleed out on us. And that's acute. Because when you're looking at that patient like this, and then they start to bleed out on you, well, guess what? You're going to start to hang some blood on this patient too. Okay? And you know what? On your first 15 minutes and those type of things, you're not going to know whether it's a problem or not. Right? The only way you're going to know is if you're monitoring that A-line and monitoring that blood pressure and everything like that. And that's why it starts to become even more acute. So the clotting cascade, in a nutshell, is the way that we form clots. And when you have a patient that's in sepsis, they have a lot of issues with injury. And their body is going to naturally start to use up all their clotting factors. So we're going to give them FFP, clotting factors, pools, and platelets, and different things like that to correct and to hopefully ward off this complication that's going on here. I think that's a good place to stop.